Hi, I'm Dr. Celine Gelgich.
And I'm Dr. Tori Miller.
Welcome to Breaking the Rules.
On Breaking the Rules, we talk about all things OCD.
Obsessive-Compulsive Disorder, OCD, impacts up to 1 to 2% of the population. We are here to provide not just education, but to inspire clinicians, families and people who are impacted by OCD to be able to access the treatment they need in order to get better.
Catch us every fortnight, wherever you get your podcasts.
Hello.
Celine, hello.
How are you?
Yeah, I'm good.
Welcome back.
Welcome back. It's good to be back in our
Yes.
new space.
I know, it's so exciting. Don't think I'm going to get used to it ever, but practice what we preach, right?
I know, sit in the discomfort, right?
Yes, lots of it. This is very different to being in our studies.
I know. I always imagine in the moments like this that the clients that I work with are like, yeah, suffer.
Yeah, oh my God, totally.
Sit in it.
Yeah, I've often said this is karma for the last 15 years of exposure therapy with clients. Oh my goodness. What are we talking about today?
This is a bit of context.
Mm.
We had a meeting the other day, didn't we?
Yes.
And you raised this beautiful question about how far is too far.
Mm.
And the question had actually been asked by one of our students
Yes.
at the clinic.
Yes.
Which I think is a really, really good question because I think for people who don't work with OCD a lot or don't have a lot of experience with ERP, I think it is something that they can feel quite anxious about. I think that sometimes there's perhaps a misconception that ERP is quite cruel or really confronting. And I suppose this is an opportunity for us to kind of
clear the air.
Yeah, dispel some of those myths
Yes.
and talk about what ERP actually looks like and how far we actually go and how we navigate those boundaries and for each client make that decision about, how far is too far and when is enough.
Yeah, let's jump in.
Yeah, all right.
So a little bit more background. When our student was talking to us, provided the example of their uni lecturer coming into their OCD lecture with a chef's knife and talking about doing an exposure while that knife was being held to their throat. And there was a bit of an uproar in the class, understandably, because it's pretty full on and very confronting. It's the last thing you would expect your lecturer to walk in with a chef's knife into a lecture. And so the question was, how far do you go with ERP? And is doing something like that okay? And my short answer response was, yeah, we've done it heaps of times. Yeah. With context, obviously.
Yeah.
And then we talked about the uproar of, and I think this would probably be an interesting place to start from, was the lack of understanding of what OCD actually is.
Yeah. Yeah.
And I think that can bring up a lot of anxiety within us as a clinician in terms of if we're not working, like you said earlier, if we're not working with it a lot and we're not exposed to the frequent, reassurance for us as clinicians in terms of the ego-dystonic nature of it, which is the inconsistency with their values and beliefs, the level of distress clients have, the sheer terror, the panic, the fear, etc. I remember my supervisor telling me that one of her, when I was very early career, I think I was like 2 or 3 years out, she had just had a baby. And so one of her clients had a fear of harming children. So she took her child into therapy and allowed the client to hold her baby with these intrusive thoughts for the duration of the session. And the client was in tears and all this sort of stuff, but also incredibly grateful.
That's amazing.
For trusting her with that. And that my supervisor was saying, I don't like, the trust is there because it's the last thing you would do.
Yeah.
And so I think being able to have those, when we truly understand what OCD is actually about, our actions as therapists are actually quite empowering. Yes, reassuring in their own way, which people can get caught up in the reassurance trap.
Yeah.
But indirectly it helps build that evidence to go, you can trust we need to I'm trusting you on behalf of yourself to be able to then trust your own judgment again.
Yeah. Yeah.
So how do we, I think maybe it might be helpful to launch into that a little bit in terms of truly understanding what OCD is. Like, what makes you feel comfortable knowing, like, once you've done your assessment and stuff?
Oh, good question. Like, actually bringing like a knife into a room, or if that was me,
if
bringing
that was
my
relevant
child
for the
into
client.
the room.
Yeah, like,
good question.
what would make you feel assured as a clinician?
Well, that's so good. How do I unpack that sense of trust that I've got in the room? Because it is more than just filling out the Y box and just looking at like a Y box score, isn't it?
Yeah.
Do you know what it is? You're right. It's about the egosyntonic versus the egodystonic nature. It is about the way that our clients talk about what's going through their minds. It's about the distress that it is causing for them. It's about the existential nature, the conflict of being someone who is plagued with thoughts of what if I hurt someone, and just how much conflict and the internal dilemma of that. I want to think of myself as a good person. My desire as a person in this world is to help people grow and thrive. I want to love my family. I want to be the best mum or the best wife there is. So why am I having these thoughts? There must be something wrong with me. And so it's that, I think it's the dynamic in the room, you know, it's the way that it feels with these clients who are so conflicted and so terrorized by the what ifs that makes me feel very confident that it is in fact incredibly egodystonic. Whereas when you talk with someone, if anyone has had experience with perhaps forensic clients or someone who perhaps was having fantasies about hurting somebody, it's a very different experience in the room.
It really is.
The thoughts aren't actually egodystonic. They're very much egosyntonic. They are inviting the thoughts. They're enjoying engaging with the thoughts. And that's not necessarily with someone who might have intent to cause harm. It might even be the rage that someone feels after a breakup. Like, I hope them and their new partner, I hope they, you know,
get hit by a car
or something, you know. I remember someone a really long time ago talking about they had just this awful thing happen to them at work with their boss. It had been absolutely terrible. And their boss had then subsequently gone and I think maybe had developed a brain tumor or something like that, and then ended up in a terrible car accident. And she was almost gleeful because she, you know, it was just grief. And it was like karma. Yes, karma. You
revenge,
know, this revenge. Absolutely.
Yep.
So she didn't actually necessarily want something bad to happen, but she was kind of gleeful about it. And so the way conversations like that feel are really different to conversations that you have with someone who has OCD, because they don't want to actually be engaging in these thoughts. And they, if they would, honestly, sometimes I think our clients would gladly have a frontal lobotomy if if they could continue to function, if they could just cut out all of that thinking, they would.
They absolutely
would. So I think that that's how I make my decision with my clients, and how I feel like I trust them and feel really confident that I could put a knife in their hands, or I could get them to put a knife to my throat, and nothing would happen. Yeah.
Using the room as a barometer, I guess, to kind of gauge where that sits. Absolutely. You articulated that really well. Thanks. Way better articulation than I can do at the moment.
But I think that when you really understand OCD as being like, you know, experiencing it that way, I think that then it's really easy to trust. It's actually not hard to sit in the room with someone with OCD.
Not. It's really
in fact, I think that's why, I mean, we often end up feeling like exposure work is very playful.
Yes.
Because I don't know about you. I mean, my clients sometimes describe me as like that I seem gleeful when I'm...
Or sadistic.
when I'm doing
like,
these
you're
things
enjoying this way too much. I swear I'm not.
I am kind of enjoying it, actually. Not because I'm enjoying their distress, but because I am enjoying the progress that we're making.
Yes.
I'm enjoying seeing OCD suffer. I am enjoying knowing that this moment is going to amount to something really fantastic.
And it's going to empower our client, right? And make them
so that's
better
the bit I'm enjoying.
It.
I'm not enjoying I'm not gleeful about the terror. I'm really
like
I'm loving the fact that that they're going to get better because
Yeah.
of this. Yeah. So it
Our
actually,
clients-
so it actually isn't really a hard question to sort of answer about like safety and all of that sort of stuff when you really understand OCD, is it?
Absolutely.
Yeah.
Our clients with OCD are the last person or on the planet that
Yeah.
are going to do
Yeah.
whatever it is that their thoughts say or
Yeah.
indicate that they're going to do.
Yeah, that's right. Yeah, that's
And
right.
you've articulated that so beautifully in
Yeah.
terms of it is a different conversation. And it feels different emotionally too as a
Yeah.
clinician. Like you don't feel icky inside
Yeah.
and you
Yeah.
don't feel nervous. You might feel a little bit nervous going, well, where is this going? When a client first discloses their intrusive thoughts, once they start feeling safe. But it's once they keep talking, that nervousness dissipates quite quickly.
Yeah.
Because you can be assured in your own assessment and your own judgment going, okay,
Yeah.
I can. And depending on the background we have as therapists too, I think if you're coming from, like if you're a clinician who works a lot more with trauma or family violence and these sorts of things, I think the alarm bells ring a lot stronger. So there might be a little seed of doubt in there. But trust the conversations that you're having and how it's feeling and pay attention to your body. I guess ground yourself in that moment.
Yeah.
And really pay attention to what's going on physically in your own body to read the room as opposed to getting caught up in the thoughts.
Yeah. And I think in that, take your assessment. If you are sitting with some alarm bells, take the assessment a little bit further and go beyond just what they've said, the content of their thoughts is. Go further and say, how does it feel to have these thoughts? What's it like? What does it what does it make you want to do? Because what you'll discover with someone with OCD is they'll say that the thoughts make them feel wretched and the choices that they want to make, the behavior that they want to do is that they want to hide at home, they want to lock the knives away, they want to protect at all costs.
Yeah.
Whereas someone who doesn't have OCD, where actually there might be a bit of risk there where you need to listen to those alarm bells, they might not actually have safety behaviors in mind. They might feel very justified in their thinking. And so a little bit of further assessment really is all you need to really tease it apart.
That extra curiosity.
Yeah.
Absolutely.
Yeah.
I think too, being able to check in with our clients and asking questions around just an extension of what you were saying in terms of what's going on for them. Because I know a lot of clients out of fear that they're going to follow through with whatever the thought is, that they themselves worry if they're enjoying it or want it or bring on the thoughts, or some of them will even sometimes follow through with a compulsion just to check to see if they still feel morally sick about it or if they feel disgusted or whatever else it is that's coming up for them. So it's these sorts of, because I can imagine if you don't work with it a lot, a client saying to you, yeah, but I'm worried that I had an arousal response, or I'm worried that whatever else it is, and I feel the need to check can seem scary as well. So I guess that leads us into how far is too far with exposure?
Yeah.
In a sense of how do we construct them, which we've touched on before in the past, but from an ethical perspective, I don't know about you. I feel like we work fairly similarly in terms of our approach with this, but for me, it's usually around really collaborating with our clients and making sure they're part of that process when it comes to putting together the exposure tasks. I often hear, especially on Facebook forums and stuff that I'm a part of with clinicians who work overseas and stuff, asking for advice on what kind of exposures would you do for contamination OCD or harm OCD or pedophilic OCD or whatever else it might be. And I'm often responding going, how about you ask your clients?
Yeah.
Because it's their OCD.
Yeah.
And it needs to be relevant for them and realistic in order for it to hit home.
Yeah.
As opposed to feeling like you need to do it to your client.
Yeah.
For me, it's something we do with our clients.
Yeah, that's right.
I feel like you work very similarly in that regard.
I agree. I mean, if we keep going with that example of like the knife, right?
Yes.
Is that at the randomly sort of just bringing in a knife and being like, hey, here's a knife on the coffee table and you just have to kind of deal with it in session today, has relevance if what you've discussed with your client is that their fear is about what if a knife is suddenly, like they go to a friend's house and they're not going to a friend's house because what if they're in an uncontrolled environment and a knife comes out and they're sitting on the bench and they're sitting next to it, and that makes them not want to go to their friend's house. And so what you've agreed upon is that you'll do an exposure about spontaneously being near knives, and that one day there might just be one in therapy and they have to keep walking through that door every day, not knowing whether today there will or won't be a real trigger. But I think you're right. It's got to be collaborative. It's got to be collaborative.
Yeah.
And it's also got to be consensual.
Yeah.
Because our clients have to be willing. We're not doing exposure to them.
Yeah.
As much as we need there to be spontaneity and flexibility, it needs to be worked out with our clients. Like I remember a time where one of my younger clients had emailed me during the week, and I honestly just out of just sheer volume of work that I had that week, I just didn't have time to reply in a timely manner.
Yeah.
And in the meantime, she'd gone to check in with her school psychologist because she wasn't doing very well, which is why she'd reached out. Yeah. Just wanting some sort of comfort, really. Yeah. And she spoke to the school psychologist, and she was saying to the school psychologist, I think Tori is doing exposure to me by not replying.
It's not funny.
No, I know.
It's the inadvertent.
I know,
yeah,
right?
It's the assumption she made.
Yeah, that's right. That somehow, like, I was working my ERP magic in this moment so that she would learn to be less dependent on me, and she'd just have to sit with the not knowing about whether I cared or not. And she brought that up with me, and I'm really glad that she did. And I'm glad that her school psychologist encouraged her to. Yeah. Because the truth was, I just
that wasn't the intention.
That wasn't the intention, and we hadn't agreed to that as an exposure strategy. Yeah, and we hadn't agreed that that would be something that I would do to sit with the discomfort. And exposure is not something that we don't take charge of and say you have to do this and you have to do that, and I'm just going to start whipping you because you know your
this is
OCD,
what you need to do.
Yeah, your OCD just has to go. Yeah. It needs, our clients need to consent. Now the difference with that, probably the only line that I would say there where it's different is when we're talking about parents reducing accommodations, because that is a different kettle of fish, right? That is where the parents are in charge of reducing the behaviors that they are involved in. But even then, they're not making their child do
that's right.
anything. Yeah. It's again, it's still consensual.
They're in control of their own behavior.
Which is that they are reducing the compulsions that they are engaged in. Yes. So that's probably the only, again, a bit of nuance. But I think, I think a lot of clients talk about when they come into the ERP space and I think some clinicians who haven't got a lot of experience talk about, well, am I supposed to just do this to my client and they just have to kind of sit there and bear it? Or clients are worried, if I start ERP, are you just going to randomly, just kind of bring out vomit one day? Or are you just going to,
just make me stick my hands in the toilet water?
Yeah, that's right. That one comes up a lot. Are you going to make me?
Yeah.
And it's like, well, I'm going to present options to you. Yeah. And I'm going to perhaps even make recommendations about what I think would be good. And I'm going to encourage you to push yourself. And I'm going to help you, take it as far as we think is going to be really helpful. Yeah. But at the end of the day, I can't make you do anything. No. And I'm not going to do anything to you. I am your support. And that's when
ERP becomes ineffective anyway, because if it feels forced in the therapy room, your client's going to walk out of there shitty, pissed off, going, fuck that shit, I'm not doing it.
Yep, agreed.
You're not going to get consistency at home, and we need consistency. Yeah. So it needs to be collaborative in that way that you described, of just looking at their trigger list and going, okay, well, what are we working on today? Let's pick one, because we're allowed to be messy with it and unstructured, and going, okay, these are some options. What are your thoughts? Did you have any ideas? Yeah. Let's jump into it. Yeah. There's much more ownership over that. Yeah. And motivation and want, as opposed to us telling them.
Well, that's a good point, isn't it? Because if we're talking about longevity of therapy and about reducing dependency on clinicians and giving our clients the skills to take it out into the world themselves, us doing therapy to them
doesn't breed that at all.
No, it doesn't. No. We need our clients to be in charge and to recognize that they can choose and they can follow through on these things. They can. And that we're just there to sort of champion them and cheer them on.
Yeah. We so are. Yeah. We are essentially teaching them to be their own therapists.
Yeah, that's right. Yeah. To make ourselves ultimately redundant.
Yeah.
Yeah.
And because they still are the expert of their OCD.
Yeah.
Really, because they're the ones going through it themselves.
Yeah, that's right. Yeah. Yeah. And also they're the ones living their lives. They're the ones who know how often certain triggers come up.
Yes.
How much a certain compulsions impact their lives, how much functional impact it has.
Yeah.
You know, they need to be the ones who choose it. Otherwise, we'll just if you build exposures based on sort of this intellectual idea of, well, the one I think you should work on this week, you know, is you know,
XYZ.
XYZ, but then they're not actually going to be triggered by that.
No.
And yeah, what's the point?
Yeah, exactly.
So I think answering the question of how far is too far, I think that us doing exposures to our clients that they haven't consented to or that they're saying they're not ready for yet, and you haven't got that agreement that, you know, or their willingness or their collaboration, right?
Yeah.
If we did it to them anyway, I think that would be too far.
Yeah.
I do think that would be too far.
Yeah.
Yeah.
It's a very fine line because we've talked about this before too. I think in one of our previous episodes is, no, we have, I think. Have we? Anyway.
I don't know what you're going to say.
Sorry. Is gently encouraging our clients to and teaching them that they can cope with hard things.
Yes. Yeah.
So it's a very fine line between making a suggestion, them going, oh, I don't know, or I don't want to do that.
Yeah.
So I often come back with, you might not want to do this yet, but it's on your trigger list.
Yeah.
And you've told me before you want to do it.
Yeah.
I'm hearing you. I'm respecting that.
Yeah.
How can we modify this? How can we break this up and make it messy so it's still not right?
Yeah.
How can you take ownership of that?
Yeah.
I think is the way to be that encouraging clinician on the side, cheerleading them on, going, I'm hearing you, but it's a yet because it's there. We've planned for it. You've talked about it. And I know you can do the hard thing, but I'm hearing that you feel like you can't do it yet.
Yeah. Yeah. I love that.
I think
love
that's
the use of that
an
word.
important distinction because what I'm hearing in my head is almost supervisees going, but we've talked about, you know, encouraging them to do the hard things. So which one is it? Do I tell them what to do or do I listen? Like, you know what I mean? Like it becomes this tug of war.
Yeah.
And we're not wanting you to kind of get lost in the OCD argument either.
Or like my client hasn't consented to do hard things, so therefore we can't do hard things.
Yeah, because we don't want to collude with OCD. So I guess the other thing to mention there is and this is the nuance of it as well, know when you're talking to your client and know when you're talking to OCD.
Yeah. Yeah, that's right.
And what that might sound like is increase in anxiety. Like when you're talking to OCD, increase in anxiety, increase in distress, increase in what if thinking, maybe some anger, frustration. But calling it out and going, I think I'm hearing OCD.
Yeah.
We're just going to pause for a second. Let's put that aside. What are your thoughts?
Yeah.
What do you, and they might not know.
Yeah.
Because they might be in a freeze state or a fight, flight, or whatever else it might be.
I love that. I love that reflection. It made me think of a young person I'm working with at the moment who turns up begrudgingly to therapy, but then arguably because of her age, you know, if she really didn't want to come, she wouldn't. Like you can't make an older teenager do anything, right?
God, no.
But she doesn't want to do ERP. And every session she comes in and she complains and says, I don't want to do it. I'm too tired. I don't have the energy. It hasn't been so bad this week.
Yep.
But ultimately, I know that in those moments, she is in the room, which tells me that she does want to work on it.
Yeah.
But these are expressions of a desire to avoid because she doesn't want to feel like shit, right? And of course, who would,
No
right?
one likes feeling like shit.
So, but we have this sort of because we've got good rapport, because we've previously talked about it, because we've talked about her ultimate like choice to avoid and her wish that she didn't have to avoid anymore, that she ultimately wants to be rid of OCD. I take that as an opportunity to tune into, to not take it too literally, to tune in, to do the check-in, to bring her back to her ultimate goals and wishes for therapy, even connect it to, come on, if we keep going, we can end therapy, right? Like I think you're getting so much better.
Yeah.
Like why stop now?
Yeah.
And then ultimately get to a point where I see it as encouragement, not pressure.
Yes.
Where she says, okay, fuck it. All right, let's do it.
Yeah.
Let's do it. And
Because
then
she ultimately has the final say.
yeah, that's right.
Right?
That's right.
Yeah.
That's right. Yeah. One of the things I was going to ask you about, which I think is really interesting, is that let's say we have a client who is willing, right? And has said, yeah, no problem, let's go for it.
Yeah.
But then they spike, right?
Yes.
They get flooded.
Yep.
Their anxiety peaks, right? How do you as a clinician make the decision about how far you keep pushing, and when do you pull back and pause and say, that's actually enough for today?
Yeah.
Or no, like ride this wave. Let's keep going. Let's not, I'm going to trigger you again. I'm going to trigger you again, you know?
Yep.
How do you
really
make that
interesting
call?
question.
Yeah.
I err on the side of, well, first of all, my internal reaction is, fuck, I went too far. and then externally, I'm like,
we got this.
Yeah, basically. Just lots of grounding. I head straight into grounding.
Yeah.
In a sense of going, okay, we're right in it together. I'm here with you. Listen to my voice, like hear my voice. What can you see? What can you feel? What is OCD telling you? So I go into reflection.
Yeah.
And observe, like I go into observing mind.
Yeah. Yep.
Really, in terms of just taking that step back. And I know that the client will struggle to do that because they're right in it, and their frontal lobe shutting down, their amygdala's hijacking everything. So I have to be that voice for them to then, and then you can just kind of see the shoulders drop slowly and the breathing kind of smooth out, and they start to hear you and they start to respond. And then we go, okay. And I always ask my client, I'm like, okay, where are you at? I don't track SUDS to make sure they're coming down from a habituation perspective. I check them out for myself to see, or check in about them for myself to see where we need to pitch it. Yeah. In terms of like, okay, you're still sitting at an 8 out of 10. Yeah. Or you're still sitting at a 7 or something like that.
Yeah, I'm the same, yeah.
Yeah. Just for me to kind of gauge
me too.
where they're at. And then saying to them, all right, we're just going to keep sitting with this. So lots of diffusion, lots of grounding, lots of sitting in the discomfort. And then when they're able to talk to me a little bit more freely, I'm like, okay, your frontal lobe's starting to come back online. I'm like, what do you want to do now? We can do a repetition.
Yeah, would you go again?
Do you want to go again? Or have you had enough for today? And we can repeat this at home because you need a break. Yeah. Sometimes I'll say, can I have a mini break? And I'm happy to go again. Or I want to do it again. Yeah. Or I need a break. Can I do it at home? Yeah. So that's how I do that.
Yeah, me too. And I think the only other thing that I do, which I know you do as well, is like check the clock.
Oh, yeah, totally.
Like if session's coming to an end.
Oh, you wouldn't
don't
repeat.
Go again.
Don't repeat.
Don't go again.
That's a no-brainer.
Because otherwise you'll be leaving your client in a panic state and ushering them out the door, or you'll be 15 minutes late for your next client while you ground your client and prepare them for leaving the session. Yeah. And which is, never a fun experience. Oh. Yes. Yeah, I agree. Because I think that question of how far is too far often comes up, not to see sort of broadly conceptually about how do we plan an exposure, but also in the room.
Oh, totally.
Am I hurting my client? And I think we've got to come back to this, to the knowledge that panic and fear is not
to be feared.
Yeah, it's not dangerous.
Yes.
It's uncomfortable. Experientially, it's awful. It's distressing, but it's not dangerous.
No, we don't have to react to it. If we react to it, we're teaching our clients it's scary. Yeah. We're teaching our clients you might as well just keep doing compulsions.
Yeah, that's right. That's right.
Know? So if we're the anchor in the room, and this is, I was going to say this before when you talk about your client as well, we become their anchor to then be able to provide the space, hold the space, hear it, let it breathe. Yeah. And regulate. Yeah. And that's co-regulation. Yeah. Right? So
agreed.
That's how we go about it.
Yeah.
This has been such an interesting topic.
It has. Yeah. It has. Okay, so
Summary.
Okay, so having a really good understanding of OCD helps you to really understand the question of how far is too far and how to pitch it.
Yes.
How far is too far is really client dependent. It's contextual. Yep. There ultimately is no danger of doing, like having a knife in a room with someone if we're talking about OCD. Yep. And we need to be able to trust our clients. Yep. And how far is too far in relation to our clients? We have to remember that we're not doing it to our clients.
Yeah, we're
that
doing
we
it with
can
them.
go too far if we're not doing it with them and
Yes.
collaboratively. And also we can think about that question of how far is too far in the session. And just I think there's a lot of what's come out of our discussion today is lots of talk about how the dynamic, the
Yes.
experiential component of therapy, not just the, oh, your SUDS is at 9, therefore we can't proceed. Your SUDS is at
Yes.
5, therefore we can.
Yeah.
You know,
yeah, not to get caught up in that.
No, it's
Yeah. We can hold it.
Yeah. Did I miss anything?
No, I think you did a beautiful job.
Oh, thanks.
All right. Thanks, guys, so much for listening. We'll catch you in the next episode.